Femoral hernia. So before we go for the discussion on femoral hernia, let's take a look at the anatomy of your femoral canal. So this is again a very important question where they have asked you regarding your bounding. So it is bounded laterally by your femoral vein, anteriorly by your inguinal ligament, posteriorly by your iliopectineal ligament, and medially by your lacunar ligament. So femoral canal is the space which is exploited by your femoral hernia. It is much more common in women compared to your male because female pelvis has a different shape which is increasing the size of your femoral canal, and it is much less common compared to your inguinal canal. Now, what is your important differentiating point between your femoral and your inguinal hernia? Femoral hernia occurs below and lateral to the pubic tubercle, whereas your inguinal hernia is going to happen your above and medial to your pubic tubercle. It is usually seen in upper leg rather than in the lower abdomen, and it may be easily missed on your examination, and 50% usually present as emergency as they have your high risk of strangulation. So there are few important differentials which you need to consider while diagnosing your femoral hernia, which include your inguinal hernia, lymph node, saphenous varix, femoral artery aneurysm, Schwartz abscess, and rupture of your adductor longus. So there are no specific investigation in your routine cases, but when you have your uncertainty, you might do a USG or a CT scan. Now, the most important topic from where your femoral hernia questions are framed is regarding your surgery. They have asked you regarding your surgery names and which surgery is used in your whether as an elective or an emergency setting. So, first we discuss regarding your low approach, which is known as your Lockwood approach. So, what happens over here is a transverse incision is made over the hernia. The sac of the hernia is open and its contents are reduced. Now, the sac is also reduced and the non-absorbable sutures are placed between the inguinal ligament above and the pectineal ligament overlying the pubic bone below. A small incision can be made in your medial lacunar ligament to aid reduction, but there may be an abnormal branch of your obturator artery just deep to it which can be bleed, and hence it is important to be knowing regarding this obturator artery anatomy, else you might injure it. The femoral vein lateral to the hernia needs to be protected. So these are your few important basic steps of your low approach or your Lockwood approach. Even if you do not remember the steps, please do remember the name of the surgery. Then you have your inguinal approach, which is your Lothian approach. The initial incision is similar to that of Bassini or Lichtenstein repair. So what happens over here is the spermatic cord or your round ligament, if it's a female, is mobilized, following which your transversalis fascia is opened from your deep inguinal ring to the pubic tubercle, avoiding any injury to the inferior epigastric vessel. Now, this gains entry into your extraperitoneal space. Now, a femoral hernia lies immediately below this incision, which can be reduced by a combination of pulling from above and pushing from below. If necessary, the peritoneum can be opened to deal with the contents. So, once it is reduced, the neck of the hernia sac is closed with sutures or a mesh plug, protecting the external iliac vein throughout. Alternatively, a sheet of fat mesh may be laid over the defect in your extraperitoneal plane. So, the layers are closed as for your inguinal hernia, and mesh into the inguinal canal is placed to protect against the development of a future prospective inguinal hernia. Now, the most important surgery is your high approach, which is also known as your McEvedy approach. So, this is an ideal approach in your emergency situation. So, what happens over here is McEvedy has described a paramedian incision, which is nowadays uses the Nahes modification, that is a transverse incision just above the inguinal canal centered to the lateral border of the rectus muscle. So, the anterior rectus sheath is incised and your rectus muscle retracted. Now, the surgeon proceeds deep to this muscle in the preperitoneal space. The femoral hernia is reduced and the sac is open to allow your careful examination of your hernia contents. In dubious cases, the bowel is replaced into the peritoneal cavity for 5 minutes and then re-examined. following which your femoral defect is closed with your sutures or mesh. So, McAvity approach is usually an ideal approach in your emergency operation, and most of your femoral hernias actually present as emergency situations because they often remain undetected. So, the preperitoneal approach may be extended to gain access to repair bilateral femoral hernia through a single incision, and this is called your Henry's procedure. Now, this femoral hernia can be measured, can be treated with your laparoscopic procedures also, which includes your TAP and TEP. Thank you.